Thinking the most important aspect would be how do you treat women at home would reflect how you would treat women at the workplace. And it's important for us to remember that human beings, irrespective of the gender, is valuable. So with that, we'll go into the next session, which is, I'm sure, much awaited for many who are in the audience today, and that was the role of big data and AI in healthcare. And to lead that session, the panel, may I request Mr. Essam? Mr. Essam Algobaisi is from Saudi Arabia. He was on the panel yesterday, and today he would be moderating this session. And we would bring the other speakers on: Jassim Haji, Otto Metzger, and Ronald Razmi. Right, I would leave it to Essam to moderate and take them through, introduce the speakers or the speakers of the panel, and we would have time till 1 p.m.
Jassim is here, and Otto, Ronald.
Are we sitting on that seat?
Yeah. Like that.
Are we moving chairs? Move the chairs?
Yeah, please, your name. Good afternoon. I know this panel, it's before lunch. Don't worry, I will try the best. I will talk in this panel about the role of the big data and artificial intelligence in healthcare. The panel will explore the healthcare data, which includes statistics data from patient records, diagnostic, images, and report, and dynamic data from best monitors or remote patient monitoring is largely unstructured nature. That said, it goes beyond the capability of the traditional analysis tools to handle such complex. In this panel, we have our expert. It's Dr. Jassim Haji from Bahrain. Dr. Jassim, president of International Group of Artificial Intelligence. Also, his executive advisor to His Honor Sheikh Nasser Artificial Intelligence Research and Development Center. Hi, Dr. Jassim.
Thank you for the
Also, we have Dr. Otto Metzger, Associate Director, International Strategic Initiative, Dana-Farber, Harvard Cancer Center. Hi, Dr. Otto. Also, we have Dr. Ronald Razmi, Managing Director, Zoe Capital, author of the just published book, AI Doctor, The Rise of Artificial Intelligence in Healthcare. And he shared with me the book. Thank you. And congratulations. He spent like 3 years to write this book.
Yes.
If I write. Ron is a former cardiologist. Hi,
Hello.
Ronald. Let me start with you, Dr. Jassim. I want to ask you about the AI in Bahrain and specifically in healthcare sector. If you can give us some information about it.
Thank you. Pleasure to be here with the elite healthcare professionals. I'm not a healthcare specialist, but we work on AI in every domain in the country. Just to give you a little bit of background of AI in general, in Bahrain, we started in 2017. That's one of the first in the region. Working on AI, establishing a society and working in different parts of it. 3 years back, His Highness Sheikh Nasser bin Hamad Al Khalifa, the chairman of the National Oil and Gas and the National Security Advisor, has established an AI Research and Development Center in the kingdom in an area called Joe, which predominantly focuses on development of AI for practical uses. So it's not just a research that puts on a lot of theoretical and academic background. So actually we started with a team of 10 and we're reaching now up to 20 data scientists and AI. These are all university graduates from the kingdom that work and train on this area of priority. And the aim is to make the kingdom as the center of research and development of AI in the region, and that's our big target, and provide more opportunities. We have over 15 universities who are working closely with us on academies related to AI, whether it's direct syllabuses or indirect. But we managed to implement 65 projects in general in artificial intelligence and over 38 entities, be it in the oil and gas in general, in financial sectors, in education, in banking, insurance, and the government entities in general. But in healthcare, we're also working with different entities, whether it's government hospitals, there's Nahra, a few private hospitals, and Supreme Council for Health. Namely, I mean, I can go through them probably later if you want in details, but they're related to back end and front end. See, I think sometimes the focus is on how AI is helping the doctors to perform their duties more efficiently and effectively, and probably replace some of the human capitals. But we don't focus as much on the back-end activities, which are as important for the healthcare. These are including the shadowing of doctors and nurses, how the AI can predict, for instance, the instance that happens. How do we provide the professionals at certain times? How do we envisage and predict the medicines? I mean, one of the biggest problems that probably we have here and different parts of the world, you either have influx of medicines that they expire and you throw them out and that's costing you a lot of money, or you have a shortage of them because you don't anticipate that kind of medicines come, because there is no correlations between these two. So this is something that we, tightly work on, and even storage of the medical equipment, at what point, at what areas, and how the stores are managed, what the sensors that are provided to the nowadays, etc. But I'll talk about more later about maybe what are the areas that we have already implemented and what are the results.
Thank you, Dr. Jassim. Prof. Otto, you are from Harvard, so in the Middle East, when anybody hear about Harvard, it's different, as we talked before. Can you share with us how the technology is used in oncology?
Well, thank you so much. It's a pleasure to be here. I would like to thank the organizers for the invitation, and it's nice to be in a panel with experts in this area. So it's my first time in this beautiful country, and it's very nice to be here in this region and interact with colleagues. So my name is Otto. I'm not an expert into artificial intelligence. I'm a clinician who have been involved in clinical research for the past 20 years and very involved in patient care. So I take care of patients with breast cancer on a weekly basis.
Can you, doctor, just the mic? Yeah.
Yes. And we, as clinicians, we're dealing with this revolution that's happening with AI on a daily basis. And there are many angles to that. And I think there are positive and negative aspects of what's happening with artificial intelligence. So we're starting from the good and the advantage of technology and the implementation of artificial intelligence in our clinical practice. I would start by saying that this has a lot of value in terms of clinical research, and we're using these tools in our daily practices. So the Dana-Farber Cancer Institute, which is a hospital affiliated to the Harvard Medical School in Boston, it's a place where research is at the forefront and patient care is at the forefront. We really try to do both hand in hand with research informing patient care and patient care informing research. And as a trialist, I pay a lot of attention to the challenges that exist in the conduct of clinical trials. And we have, at a given time point, we have over 1,000 clinical trials opened across the Institute. In my department in breast oncology, we often have close to 100, 200 clinical trials opened. And it's very hard for the clinicians when seeing patients to try to match to see what of these clinical trials could be good for our patients, what of the early stage clinical trials with these very innovative targeted drugs could be good for a given patient with metastatic disease. And so we have implemented and deployed artificial intelligence to link the genomic data that we have from our patients with the clinical data. This is called Match Miner, and basically through Match Miner, we get lists of potential clinical trials that could be useful for specific conditions. And this has been a transformation because through the capabilities of artificial intelligence, we have potential studies with target therapies that could be useful for specific genomic characteristics, which as a human being, it's very hard. It would be extremely time consuming for the clinicians to go and try to find all this data and match things correctly. So I really feel that artificial intelligence and all the capabilities that exist are going to be really very useful for us. There are many aspects that are still in the early days, but as an example, we deal with electronic medical records in the United States that are extremely time consuming. The time that we have to spend in documentation, ordering tests after we see patients, it's a lot of time, and we're hoping that with this new technologies, all of that is going to be automated. For instance, the medical notes itself, when we talk to patients after we finish an appointment, we have to document all this conversation. So we have a pilot ongoing at the moment at our hospital where the computer is listening to the conversation and it auto-generates a note summarizing all the conversations, the decisions that were made. And this is beautiful because we as clinicians, we want to spend time with patients. We don't want to spend time with a computer doing documentation. So I think that there is a real revolution happening. In terms of the things that are a little bit more challenging and sometimes complicated is how our patients itself are interacting with these tools. So we take care of a population that's highly educated, that basically come for second opinions. A lot of times they come from overseas. And sometimes they interact with these technologies like ChatGPT and they get responses about potential treatments. But we have to understand that medicine is complex. And I don't think that the machine in itself is going to replace us. It can be very useful once you have a professional in the back end that's able to digest the information. But patients are interacting with these tools and they're getting informations that are not necessarily helpful for their management, because even within oncology, there's a lot of variability from patient to patient. There are a lot of intelligence that goes behind clinical decisions that cannot be done through machine today. So there are many aspects that are complicated, but in general terms, I see this coming as tools that are going to be very useful for us in our clinical practice. And as I said, some of them, they are already a reality today.
Thank you, Prof. Dr. Ronald, I know you have your book, it's like the new baby. Can you tell us what are the key learning from the book eDoctor about the current and future use cases of AI in healthcare?
Yeah, thank you for the question. So it's important to understand the context of sitting down and writing a book for 3 years. And the context is that I was a cardiologist. I mean, I'm glad to see the CEO of Mayo Clinic here today, because that's my alma mater. And, you know, after I finished my training, I decided to go on the business side of healthcare. After spending all those years becoming a cardiologist, I went back to business school and then joined McKinsey in their healthcare practice. And then I saw the digital health revolution coming back in 2010 and 11 and left McKinsey to start a company. And I was running one of the first digital health, which later became a health AI company, for the next 7 years. What I saw was the meat grinder that a digital technology walks into when you bring it into the healthcare system. And when we exited that company and I moved back to New York from San Francisco, first of all, I had to take a year off, because when you're running a technology company, you don't even have like an hour off, it's ongoing. But synthesizing the learnings from the first decade of digital health, where a lot of great ideas, things that really sounded good on paper, never ended up working or gaining any adoption in healthcare. So this is the first thing to understand, is when you're bringing a digital technology into the practice of medicine, the fact that it's very hard to get the data for your product to work. And when you're talking about AI, AI doesn't do anything without data. So I was coming in and, you know, having been an ex-physician, my friends were the CEOs of hospitals and department heads, so I would go to the CEO of Ascension Health, who was a personal friend, and say, I want to get the data, why don't you lean on your technology staff to give us the data? In spite of having friends in the high places, you can have a scenario where the IT staff were like, well, we're doing this EHR implementation, we're doing this, we're doing that. Would you like us to deprioritize that to advance this project? So they would scare the CEO, and the CEO would back off. So the reality is that for people who are developing these technologies, digital health, health AI technologies, doing the analysis up front around availability of data, workflow adoption, the business model for customers. So you're the CEO of a health system, you're the purchasing manager for a pharmaceutical company. You have hundreds of applications that are being pitched to you in a given year. How do you choose, and you have limited budget, how do you choose the 2 or 3 things you're going to buy and provide to your staff? So doing the analysis up front, figuring out, is this a mission critical use case? Is the data in good enough shape for my product to deliver the output, the desired output? Will it fit into the existing workflows? If you don't do this analysis up front, you become part of the 95% of digital health and health AI solutions that never gain any adoption, and you go out of business within a few years. So right now, we spend a lot of time as investors analyzing companies and deciding which technologies we're going to be investing in. We have noticed that out of 50 to 55 companies we evaluate, only 2, maybe 3 end up making it through our selection process as this is worthwhile investing in. So you're looking at about 5 to 6% of the solutions being developed that have a chance in adoption and being paid for and long-term sustainability. So the book really is a framework for people who are developing, people who are buying these technologies, people who are investing in it, to figure out how to evaluate. Before you spend 3 years of your life building something, it's good to evaluate whether somebody's even going to be willing to pay for it.
Thank you, Dr. Ronald, and I agree with you totally about the when we say when we have any machine without the data, it's not can't do anything. Yeah, so we should have the healthy data, and now we will talk about the big data. So if I ask you, Dr. Jassim, about the big data, I know in Bahrain there is a new technology, and there is AI technology, new technology. So let me ask you about the AI ethics and governance in the health.
Well, I mean, to start with, if you look at the recent European Union's Act on Artificial Intelligence, which took them 3 years virtually to prepare it. And I think the 3 years, the first 2 years was wasted, because since end of 2022, a new phenomenon called generative AI, which is ChatGPT and Gemini and others came. So the whole concept of rationalizing and understanding AI was changed. I told this doctor, I stopped writing books about AI because it's moving so fast. Yeah. Even I don't advise people to do PhD in AI, because by the time they finish it, it's an old technology. We're talking about a matter of days, less than a week on the development and the node. So the European Union tried to look at the conceptual part of it, and they put it into phases. But it's interesting, they looked at the most risk-driven AI implementations, and there were 2. They said those 2 are on the red line, and one was the education and healthcare. Of course, healthcare in terms of criticality to the human is more important, but nevertheless, education, because we're talking about educating the new generation, and how do we bring them to that level from universities, from which age you start. So the future of training and education is, by all standards, is going to be dedicated virtual lecturers in future, so that the children of the decades to come will be taught through individual one-on-one lecturers that will provide the data that is collected from each child, and they will be monitoring them and customizing the lectures to what is their strength and what are their talents. Now, this will continue through their journey in the school and universities, and they will be used as an assessment and development during their career at work. And now the same things will be applicable from the healthcare. So if you look at collecting data from the children from the birth, from one sources, and developing them to be able to analyze their entire journey. So you don't go and start testing them at every phase. Now, I think this is a target that most countries trying to reach. And I know that on the high level, there are, for instance, United Nations also, they came up about 10 days ago with their own strategy on AI. And I know I'm part of it. the State Department of US, they have something that we are probably one of the first members in GCC, that driving ethics and governance related to AI, because everybody thinks that AI is a unique development of algorithms and you get a percentage, and that's the wrong conception. Most of those data can be biased, whether you can do it from the bias, from the data point of view, or when you get to the algorithms. Depends how do you want to bias it, how do you want to manipulate it. So it's very important to look at this part. How do we look at the development part of it and who's responsible? And when you give it back, for instance, to the hospital, who's the owner? Who's responsible for that algorithms? Who will be developing it? Now the same thing happens to the autonomous cars, to the other parts, but on the healthcare this is a very important, and that's why there's something new called explainable AI. How do you explain that algorithms that you developed? You know, why did you do this? How did you do it? And what are the outcomes? Even to a layman, of course, the future will be with something called no code, zero code, where we will have physicians developing their own AI solutions without a need for a developer. We will simplify it in that level, so everybody can just drag and drop it. Like in the past, it took us 6 months to build a website. Now, any child can build a website within minutes, especially with generic AI. So I think the algorithms that comes with it, but to conclude that, even the governance of AI, it has to be by sectors. We can't just put something generic and say this is applicable to health, education, finance. So health sector, it needs its own governance, which we are also working with Nahra to look at it. I know WHO, they have a policy and guidelines that's developed for AI, but still it is on a very high level. So countries, based on their specific requirements, need to customize it.
Thank you, Doctor. Dr. Otto, just when I talked with you before this panel, I just remember when I visit my doctor, when I talk with him, he didn't see me. He's just working in the computer. And I think this new generation from the doctors, they are using the computer a lot for the input the data or something like this. I would like to ask you about the doctors. Technology is taking up a lot of time while working. How do they deal with that?
Yeah, this is a very relevant question, and this is totally true. At least in the United States, we as clinicians were faced with this big burden that comes with documentation and electronic medical records that were built not long ago, but they were not built to be fit for purpose in the sense that they're not built for patients and not built for clinicians. What's behind the whole enterprise is that they are very good for billing purposes. So we as clinicians, we say that to do a documentation after we see a single patient, we have to do 100, 200 clicks to fill out all the fields. And hopefully, as I said, this is a field where with the artificial intelligence, this is going to be a big transformation because the computer is going to listen to us, generate the orders, create a note. We can revise this information, but at the end of the day, what is important is that we as clinicians, we spend time with patients and we're able to have this physician-patient relationship and have a conversation which makes the whole job gratifying, makes the patient's experience much better. It's not nice from a patient perspective to have a clinician that's trying to click and do a million things at the same time. So in this pilot that we have ongoing at our institution at the moment, I mean, this is happening. It's real. So we talk to patients and we open the computer and the medical note is done. And it's pretty reasonable. But again, what's the most important aspect for us as physicians and for patients, it's not the documentation in itself. It's what patients were able to absorb and understand about their illness and the treatments that they're getting. not the actual documentation. So there is a real potential there. And I just want to make a quick parallel to the point that you made about data availability. And I think that this is critical because we want to have tools that are able to learn from data, right? We know that the real power of artificial intelligence is to be able to have the machine to digest data and to present to the user in a format that you can act on. But in medicine, the data availability, it's a big problem, and it's a problem for reasons that are important because we want to protect patients' identity, we want to protect patients' data. So it makes quite complex to have real large data and big data shared despite a number of initiatives that exist. This is going to be a major problem because, as you correctly stated, it's very hard for us when trying to implement a new tool that's able, let's give a quick example, tools that exist nowadays to help with radiologists to interpret images. We don't know exactly how these tools were created, what data informed the creation of those tools. And so we don't know if the population that was used in the development of the algorithms, it's valid for the population that we're treating in a given hospital. What we're doing at the Dana-Farber Cancer Institute from a data perspective in the genomics space, it's very interesting because we created through our computational biologists and a lot of people involved academically from this artificial intelligence side, we developed systems where we're able to interpret genomic data within our system, and we're able to interpret genomic data that's sitting at different places in different countries. And we're able to merge, compare, but the data doesn't leave the institutions. So basically, the protection that exists for the data never leaves a certain place. So we're able to do this cross-boundaries analysis that keep the whole data protection in place. And I think that that's a field that needs to evolve more and more because we want to develop systems that are basically not just applicable to the population that we're treating in Boston or in the region, but that can be validated overseas and a population level. And the last point is, how do we define standards? How good validation is enough for AI? So when we, as a trialist, when I'm testing drug A versus B in a registration phase 3 clinical trial that goes to the FDA, we had a pretty serious predefined set of rules to say this is good enough, this drug should be used in clinical practice. But what are the set of standards that exist for the implementation of those tools in our clinical practice? And I think that those are things that we, as the academic communities, we have to take it very seriously and define standards so we can adapt to tools that have been validated. So the field is moving very fast, and hopefully we'll come to a point where we'll have a defined set of criteria to say a certain tool is good enough for clinical use, because there are potential harms in adopting tools that have not been validated appropriately. So it's really a very interesting field.
Okay, I think from your face, Ronald, do you want to add anything for same question? Dr. Ronald?
I'm sorry?
As a doctor, what do you think about this? For the doctors, yours.
Yeah, I mean, I think a couple of things to keep in mind is, number one, let me speak to this from a business point of view. If you can't get the data, and in healthcare, you know, let's say somebody's at Dana-Farber and is seeing you for an oncology issue, some of that data might be in paper they brought with them. So if you have an AI tool that's helping you make a decision and it's lacking critical data that's sitting on a paper, that tool isn't going to be able to help you.
Okay.
So that's one issue, is healthcare data is fragmented. It's in different formats. A lot of times you're getting the data in from a radiology facility, and it's in the form of a PDF. You have to first perform OCR on that, make it into structured data elements before an algorithm could run on it. So there are a lot of issues. These issues are investment killers. Like, none of those companies are going to live long enough for these issues to be solved. So that needs to be taken into account up front when you're deciding to invest or if you're buying that solution for your medical center. The other thing is this issue of, if I have AI in the name of my company, I am now cool, I can raise money, and I can sell my solution. And the issue with this is, no matter, and Dr. Haji mentioned, the field is moving fast, the technology is changing every day. We've seen what happens with what's happened with generative AI, and we have no idea how much more powerful it's going to be. What is not changing is the fact that no matter what solution you're building, it needs good thinking around fit within existing clinical workflows, business model for the buyers, data availability. The analysis is never going to change. Remember, in the early 2000s, when the .com era was happening, Pets.com became a multi-billion-dollar company with no business model because it had .com in its name. Yeah. Any company which was an internet company, and people were saying the old business rules are out. This is a new economy. Now you can build companies on the internet, and you don't really need a business model or what have you. All of that turned out to be a load of crap. You need a business model. You need good thinking when you're developing solutions for healthcare or other industries. I would argue healthcare is one of the most convoluted sectors of the economy, because the user, the person who benefits is a patient who doesn't know anything about a tool that the doctor is using. The doctor is not the decision maker on who buys the solution. You have committees and medical centers, CIO, CMO, the business executive, that get together and decide which technologies they're going to buy. And guess what? None of them are the payer. The payer is the insurance company. I mean, this is the years that I was running Acupera in San Francisco, I had many technology entrepreneurs who had sold their companies. Now they had a lot of money. They were in their mid to late 30s, and they were looking for their second act. And they thought, I'm smart, I have money, I know technology, what can I do? And it was like, okay, let me go solve problems in healthcare, because healthcare is an industry that's really behind the curveball in terms of a lot of problems without a lot of good solutions. What I saw all the years that I was in San Francisco was every one of these technology entrepreneurs ended up leaving healthcare with their tails between their legs, because they didn't know what they were walking into. Healthcare is different than a typical internet company, because you have so many stakeholders. They each have their own point of view, and obviously, I was speaking at the United Nations Gender Equity panel a few weeks ago. One of the things I mentioned is Netflix could have part of your data on what shows you watch. Amazon could have part of your data on what items you buy. That's enough for them to have a profile on you to do some good things for you, recommending products, recommending better shows, and so forth. In healthcare, I can have all of your data from your entire life except a set of labs you had done yesterday. And guess what? In those labs, there was something alarming, like your creatinine jumped or something bad happened. It nullifies everything else. Incomplete data in healthcare is a real problem, and it could lead to catastrophic decisions. So one of the things that we possess is we can weigh the cost of making a mistake we can say all the data is pointing in this direction, but my general intelligence tells me if I walk through that door, there's someone with a machete waiting for me. An AI algorithm can't weigh the cost of making a mistake. It just does what it's trained to do, and it does it every time. So that's a big issue.
Yeah. Thank you, Doctor. And we have 11 minutes, so I want to ask you a question, and in 1 minute, if you can, for you, Dr. Jassim, can you share with us the role of the generative AI?
Well, I wish I brought my Gen AI to answer in 1 minute, but I'll try to make it in saying that the large language model, which are the basis of the Gen AI, now it's an open training of that. We're using, as previous speaker said, that globally to train those data, and those data cannot be specific to use. And that's why we see a lot of tools that are coming ready-made are meeting no more than 30% of the medical centers, because whether they are made for, like an Oracle systems that's meeting the majority of the population, or it's meeting halfway to what you do. So the solution to me is countries are going more and more on closed data. So they take their own large language models and train them to what is specific to them, to what is specific to the hospitals. And then from there on, they can customize and develop solutions which are meeting that community and the patients.
Thank you, Doctor. Dr. Otto, in 1 minute also, I know for this question it's need more than maybe 1 day. Can you share with us the last technologies used in the cancer treatment?
Absolutely. So I am an optimistic by nature, and I think that those things are going to be incredibly helpful for us. I'm going to share briefly just like a quick experience about like using these chatbots that are able to digest data. So as an oncologist specialized in breast cancer, I treat just patients, women with breast cancer for 20 years. So no matter how much I try to study, I will never remember all that I learned during med school, and I won't be updated with the most recent information that exists in cardiology. So if I have a computer system helping me, and I'm seeing a lady with breast cancer, and the computer pops up and say, this patient have a genetic condition that may predispose to cardiac risk, for me, this is very relevant. I wouldn't be able to get that. I wouldn't know about this new cardiac condition. So I may use this information to select a different type of chemotherapy. So it's really fascinating how technology can be in our favor. So I think that's one quick example of how these things can be very helpful when correctly deployed using the data that's available.
Interesting. Dr. Ronald, also in 1 minute, what can the stakeholder, like policymaker, investors, do to accelerate to adoption of AI in the healthcare?
Yeah, I mean, I think there are things that need to be done at the policy level. I favor a centralized, unified patient record. I think interoperability is difficult because you have to connect too many nodes. So if you have a unique patient identifier and every electronic health record in the country dumps the data into a centralized database, there are security risks with that. There are privacy issues. We know things get hacked. But the benefit is so much that if my Apple Watch data, my electronic health records from my independent allergist that I see in New York City, plus my records at NYU and Cornell and so forth, they all go into one place. It makes research easier. It's going to make running algorithms much more accurate because they have unified patient records. This needs to be done at the policy level. If we've seen anything, it's the fact that medical centers who have the benefit of keeping the data within their own four walls and electronic health records that don't want to share data could block this kind of good policy that can improve patient care and make AI possible at a faster timeline. But you need to muster the political will to push it through, which is very difficult.
Thank you, Doctor. And we have like 7 minutes for the audience. If you have any question, yes, please. And your name, please, and the question for which one?
My name is Dr. Rajal Youssef. I'm the Deputy CEO of Government Hospitals, Kingdom of Bahrain. It's a general question for the panel. I'm interested to know your take on clinical coding in hospitals. As you know, the process is long and there are chances of rejection of claim, and there's always room for improvement, improving clinical documentation, improving coding. How does AI help? What's around the corner in this area? The second question, if I may, is health technology assessment, because we, in our positions as decision makers, it becomes very challenging because you get bombarded by all sorts of technologies on a daily basis. Which one to choose? What's the algorithm? How AI can help? Thank you.
Thank you, Dr. Raja. Anyone for the first question?
I think you're talking about the insurance claims, right?
Yeah.
We have in Bahrain developed a prototype. I'm working with one of the insurance companies on how to facilitate that, because that's the insurance process. There are two parts of it. The one is the comparison that it happens between various documents, and that's AI can identify them looking at the doctor prescription, the medication, and the claim, the history. All that can be done within seconds of the time that it's taking right now. And the second part is the recommendation system and using the experiences of the doctors in the medication center, how to approve them, when to approve them based on the learning curve that it happens. Of course, it requires a lot of training over a period of time to reach the accuracy that is desired.
Dr. Otto, Dr. Donald, do you have anything to add?
My take on the health technology assessment is that there is no easy answer. This is really difficult because we don't know if the tools that are being sold, if they're applicable to our population. And it's not so clear what's the data that was used to develop those tools. So I think that trying to get some visibility into which population was used and maybe propose systems where we could adopt that if a validation is done in our country could be one possibility. I think that there is one potential exception, which is the technologies that exist today in terms of imaging. And let's take radiation oncology as an example. So once we're doing a treatment planning for radiation oncology, we know that there is it's a difficult process where we have technicians, radiation oncologists trying to map out organs to see where radiation is going. And there are tools that are being deployed and available today where the computer can do it. So those are tools that basically they are well developed in the sense that imaging, it's a type of data that's easier for a computer to analyze. And again, this is not meant to replace the human being completely. You have a professional behind the scenes looking if the mapping that the computer made for an organ is correct, because this person has been doing this manually for 20 years. But if the computer does that in 1 second, this person can just verify that's done correctly. So I think that those are advances that we're using today, and they're easier to adapt as when evaluating this, like in terms of the health technology assessment.
I'll quickly say that the AI-based coding is a here and now use case, because large language models result in a huge leap up in the capabilities of natural language processing, which has been a huge problem in healthcare because the notes full of acronyms, there's no standard way of creating notes. one of the beneficiaries of the large language models in healthcare is going to be automated coding. And then in terms of health technology assessment, obviously you said you're getting bombarded, and I have a full chapter on this topic in the book around, is it mission critical? Is the data available? Are the users going to use it? Because a lot of these decision support tools don't necessarily fit into the existing workflows, so they're not necessarily going to be used. So there's got to be a framework. There's a lot that are being built and pitched to medical centers and life science companies and so forth.
Thank you, Doctor. Another question? Go ahead. Your name, please, and the question for which panelist?
Hello, my name is Dr. Reyes. I'm a pediatric anesthetist at the government hospital. Thank you so much for all the information provided to the panelists on big data and AI. My question is, we're mostly discussing about collecting data mostly from electronic health records by humans. But in my daily practice, we receive a lot of data coming directly from the machines, like the cardiac monitor and the anesthesia monitors and the ventilator. Now, isn't it much easier for the pharmaceutical companies to add AI algorithms in the machine to help us predict any complications or harm to the patient, rather than we manually entering everything and then there's a bias as well? Thank you.
And this question to which panelist?
Anyone can answer.
Okay. Dr. Rassan, do you have any answer for this?
Me?
Yeah.
Jassim, sorry. Well, the data entry, first of all, you said the data collection from the patients. This is the problem we've seen with hospitals. I mean, we know even the BDF hospitals, the integrations of the data for the patients between the 3 hospitals have taken over 2 years. So sometimes you cannot wait for that purpose to have the generalization. That's why one of the recommendations was in branch of the WHO to hospitals to try to develop their own set of data, and as I said earlier, to train closed large language models to make their own semi-ChatGPT, and if you like, for that community, so the doctors can be able to do the chatting, whether it's to extract the data in a brief formats from the multiple sources, or to provide the recommendations from their community. This also requires what they know as loyalty of the customer. So if you have patients with historical records, that will work, but in general, it doesn't. But back to the pharmaceutical, there is a lot of solutions that we've seen going around, and people flooding it, and vendors, and I've seen them in Bahrain. But they're very dangerous to adopt. Again, I'll go back to the issue of the governing and looking at the risks related to those. So not anything that is brought and approved worldwide.
Okay.
Also, in terms of feeding directly or running an algorithm on the machine, healthcare data often needs to be combined with other data to make a decision. Data coming directly from an EKG monitor or a ventilator and so forth, in isolation, it may not be informative enough. So you need to combine it. So putting the algorithm in the machine in some cases could make sense. I understand what you're saying in terms of manually entering the data, and obviously there could be errors, but eventually connected machines where the data from the ventilator could automatically go in the electronic health record. There's data coming in from other sources, all combined. And actually, Ochsner Institute in New Orleans is running excellent algorithms in their critical care units that are running on top of the data, all the critical care data. They're anticipating developing sepsis or deterioration, and it's really been a good assistant to their critical care doctors. That's a model of how to do it. But putting algorithms directly in the machine, we might be too early stage for that.
Thank you, Dr. Ronald. As I promised on the time, sorry, the time is finished. Dr. Ronald, Prof. Otto, Dr. Jassim, thank you very much. That's our time. Thank you.
Thank you for that discussion. The panelists will be available for discussion over coffee or lunch. Please do feel free to meet them and discuss questions you have. We would come back after lunch at 2 p.m. At 2 p.m. At 2 p.m. for the start of the post-lunch session. Thank you.